much more reddish situation. For us to understand the periodontal disease is also important to memorize what does it mean, the gingival sulcus. Okay, so that will be the gingival sulcus. This is the definition of this thing. It's a quite shallow space, and it's a V-shaped, and it's a permit for us to entrance with a periodontal probe. We will discuss in the practice what does it mean. And also for us as a dentist, it's very important to check this area, because this area, so the determination of the depth of the gingival sulcus is a very important diagnostic parameter. You have to know, you have to memorize this year certain numbers, and this number is important, please don't forget it. The probing depth of the clinically normal gingival sulcus is less than 3 millimeter, okay? This information will be quite useful for you for clinical practice. Is this distance is more than 3 millimeter, they're talking about the pocket. The pocket formation is always pathological. So this is the narrow space, and we can measure with a periodontal probe the situation. Let's see again the etagingival. What does it mean, the etagingival? The etagingival is continuous with a marginal gingival. There's no direct border. So in a clinical picture, this is the free gingival, okay, here, and here's the etagingival. There's no border, okay. So we have a border, just a movable mucosa, okay, with a mucogingival line, of course. What are the characteristics of the etagingival? It's very firm, it's very resilient, and tightly bound to the underlying periosteum of alveolar bone, and also extends to the movable alveolar mucosa, which is also, we already discussed it. The width of the alveolum, the etagingival is highly variable. The front region is a little bit larger. It can reduce the premolar area, so this area, okay, and it can growing again or getting larger the molar region as well. It's very important because it helps the periodontal tissue to prevention too much chewing forces. So etagingival is very useful part of the periodontal tissue. Yeah, you can see the etagingival as well in a clinical picture. You see? So this is the etagingival here. Okay, this is the gingival junction. This is the free mucosa, and this is the alveolar. This is the free alveolar gingival, which is there's no border between the gingival cell. In the proximal papillae, this region, normally it's fulfilled this area below the contact point, and the shape is highly variable, as you know. I would like to show you this picture. So the front region is probably a triangular form, but the molar region it's a volley-like depression. Okay, this is a core area, and this thing is a contact point by the molar, and we have a facial and lingual papillae. So the form is highly variable. It's strongly influenced by the connection of the different surfaces. Okay, the color. The color is also very informative. We know that the normal color of the gingiva is a pale pink or coral pink. But during the inflammation process, it's getting much more reddish, okay? But the color is strongly influenced by the vascular subtly, of course, the characterization level, and sometimes you have to know that the gingiva contain some pigmentation as well, okay? A racial pigmentation, which is a normal condition, of course. So the normal color is a pale pink, and if you see reddish conditions, so probably it is an inflammation. The size of the gingiva, let's see the size, so this is also normal condition, okay? What do you think, what is this here? I already told you this information.
It's a pigment.
Of course, the racial pigmentation is normal condition. Okay, so the atagingiva, the atagingiva contains sometimes pigment cells. And also, this is the atagingiva, this is the movable mucosa, very, very
But
characteristic.
it's not too pale.
Sorry?
It's not too pale.
Not too?
Pale.
No.
No?
No.
It's almost white.
I think
No, it's a pale. Okay, it depends on the person, but it's normal. It's normal condition. You have to memorize the atagingiva contains so many fibers, okay, and it's a little bit the keratinization level is higher than the lining mucosa because we need some resistance against the training forces. So it's normal. It's normal. So this is a normal situation. And very easy to determine if we have inflammation because this area getting a little bit reddish, so it's normal. It's normal. So the size of the gingiva is also informative. You know, it's a summary. You know, the cellular and intercellular elements as well, and the changing the size of the gingiva, alteration in size. It's a very common feature of the gingival disorders. You should know the gingival enlargement. It's very characteristic for inflammation. Okay, the contour and the shape. The contour and the shape is also determined. There is so many other factors which can associate it with a shape. So of course the localization, you know, and the size of the area of the proximal contact is also determined the contour and shape of the gingiva, but mostly the marginal gingival envelopes the collar-like fashion, and this is the normal situation. Another thing, we already discussed, you know, the shape of the interdental gingiva. I already told you something about the form. The front region is a pyramidal, and also the molar region is a more flattened situation. So this depends on the position of the different foods, and of course the localization as well. Consistency, we already discussed this firm and resilient, and this is typical pictures. It looks like a orange peel, of course. The orange peel is a physiological condition. It could be, if it disappears, the orange peel, could be the first sign of the inflammation, but not always, because not every single patient can be detected to this one. For example, a younger age and maybe elderly age, it can also missing. So, but if we can't see the orange peel, it could be the first sign of the inflammation. Okay, so the name is stippling, and as I told you, it's less prominent. Certain age, for example. The position. Normally, the position of the gingiva is always at the CEG. The CEG is the cement-to-enamel junction. Okay, so it's normally there is a normal localization, but sometimes we receive these things. We call it a gingival recession. This is the normal situation, and this is the gingival recession. The opposite situation, the gingival enlargement. So it's a hyperplasia. Okay, so sometimes we have a recession. We have also the hyperplasia. So the level of the gingiva is also informative. If the position is not the CEG, mostly we have inflammation as well. Okay, that was briefly about the gingiva. This was the first important part of periodontal tissues. The second important part, the periodontal ligament, just briefly. It's a connective tissue, of course. It's a very important thing because there is a connection between the bone surface and then the cement layer, and it's a very thin layer. Okay, you can see it's a 0.2 millimeter, but it's highly important. Histologically, we have Typhon collagen fibers, and the collagen fibers orientation is also important to memorize because we have, and you have to know it for example, these things, this 5 things. Because we have our pressed fibers, yeah, you can see here, horizontal fibers, oblique fibers. Oblique fibers, not the name is the Sharpie fibers, okay? I think it's not new information for you. The Sharpie fibers and the periapical and interradicular fibers by multi-roted teeth. Okay, something about the function. Please memorize this thing. The oblique group. This is the largest group, and the main function, the transform. The masturbatory forces to the alveolar bone. This is the main function, and this is the most important part of it. Another part, for example, alveolar group can prevent, the extrusion of the tooth, and also resist lateral tooth movement. So we have a different function for the different orientation, but for against the chewing forces, the Sharpie fibers will be transformed the force to the alveolar bone. Some functions could be also important. We have physical function, we have a formative function, and we have some nutritional and sensory functions as well. Let's see quickly example for this. First, for the physical function, I wrote something to protect the vessels and nerves, transmission of the occlusal force of the bone, attachment of the teeth to the bone, and of course the maintenance as well. So many functions which makes this tissue very valuable. And also we have remodeling and formative functions because the intact periodontal ligament is necessary for the physiologic tooth movement. It's also necessary for the repair certain injuries, for example, and also the old cells and fibers are broken down and replaced by the new ones. How? For example, the fibroblast can form collagen fibers and also may develop into osteoblasts and cementoblasts as well. So this is the pathophysiology of periodontal ligament. And last thing is the nutritional and sensory functions. Just imagine the cement layer. The cement layer, there's no circulation at all, but they need some nutrients, and the periodontal ligaments can produce some nutrients for the cement layer. And also we have some sensory functions as well. The sensory functions mean we receive pain if we are chewing so hard, and we can produce mostly the pain sensation. Okay, third important part, the cement layer. The cement layer classification, we have a primary and secondary as you learned. And also this is the definitions classified mesenchymal tissue. Why is it important? Because the cement layer can anchor the extrinsic fibers, is a Sharpie fibers, as we discussed, and this is important to hold the tooth into the alveolar socket. And we have some intrinsic part as well, and you can see the component. It looks like a bone actually, but you have to know the cement layer is quite thin. Okay, the thickness is just less than the human hair, but it's very valuable, and it's necessary for intact function. Cement-enamel junction, the CEG, localization, mostly we have overlap. This is a normal situation. But what if we have exposed dentin, we receive a sensitivity? So unfortunately, this is a sensitivity code for hot and cold drinks, for example, and we can cure this problem with a sensitive toothpaste as well. So sometimes the patient has this problem, which is quite serious because you know, the normal life is not possible because he or she receive very strong sensitivity. Okay, so we've already discussed the thickness of the cement layer, and also we have alterations. For example, sometimes we receive hypercementosis. The cement layer is getting thicker, and it is also a pathological thing. And also resorption and repair, we have so local and systemic causes. You will read it. Of course, it's related to the general, mostly general disorders. And the last thing, the alveolar bone. Alveolar bone is a similar, like you know, another part of the body. You know, the composition. It's the same. We have a compound bone. We have a cortical bone, but maybe we can see here. So we have external cortical plate, internal cortical plate. We have some cancel bone here, and of course for us as a dentist, it's important to check the bone level in the X-ray. Unfortunately, the X-ray is not visible, the gingiva, because it's soft tissue. You should know this thing, but the bone is very, very characteristic. So this is a bone, and this is an internal cortical plate, which is clearly visible. We can see the CEG in the X-ray, and the distance between the bone and the CEG is quite optimal and roughly 1 millimeter in the physiological aspect. And if we have a bone loss, which could be characteristic of certain periodontal problems, the distance getting larger. So that ratio, sometimes we have to take X-ray. Some anatomical thing which could be problematic for a dentist. Sometimes the vestibular part of the bone is completely missing, so the gingiva attached directly to the root surface, and sometimes we have a small window. This area called distance, and is called a fenestration. Okay, so it's an anatomical situation, but it's not optimal for us because if we have a mild inflammation, the mild inflammation can produce a huge gingival recession. Okay, which it's really hard job to do the correction. So this is a penetration in distance, the importance of these conditions. Okay. There was some anatomical thing, and don't forget it, the four main components. So that was the alveolar bone, that was the periodontal ligament, that was the gingival, and that was the cement layer. These things together produce the periodontal tissues. Okay, let's focus on the inflammation. That was on some anatomical thing, and we focus on the inflammation. The major etiological factor for the periodontal inflammation is the dental plaque, as caries as well. So this, the dental plaque or the biofilm, the dental biofilm, is a primary cause of the caries and the periodontitis. Of course, we have a different bacteria. You will learn it, of course, but in third year is not important. But you can see the clinical pictures, and you see this reddish area. It's very, very characteristic for the inflammation. Okay, what is the importance of the dental plaque? If we remove the dental plaque properly, we can prevent and we can cure, you know, the periodontal inflammation, the gingivitis. Okay, so this is the importance of the good oral hygiene. So let's start with the plaque formation first. After the tooth brushing several hours, we receive a glycoprotein layer called acquired pellicle. This pellicle, it's a very thin layer on the tooth surface, and it's invisible. But by the smoker patient, we can see these brownish discolorations everywhere. this is acquired pellicle. And yeah, the problem with this layer, this is the first phase of the plaque formation, okay? This is not a bacteria layer, it's just a protein layer, but it's a very good basis for bacteria to attachment to the tooth surface, okay? So that will be the first step, and after the pellicle formation, if the patient oral hygiene is not optimal, the second deposits will be the dental plaque, okay? The dental plaque is mostly invisible, but if it's large enough, we can see. Could you say this area? So this is the dental plaque everywhere, okay? So the dental plaque is a pure bacteria, okay? This bacteria produced inflammation, and this inflammation produced so many clinical symptoms as well. You should know this inflammation called, gingivitis, and this gingivitis is quite painless condition. We have just one alarming sign, which is not so important for a patient. This is the bleeding during brushing, but it's irrelevant for a patient, unfortunately. But it's a very important alarming sign. If somebody has bleeding during brushing, so the diagnosis is almost 100% is gingivitis. Okay. But a good thing with the discositis, reversible condition. So this is a dental plaque. Okay, so it's quite problematic because this is a pure bacteria, and this bacteria can produce inflammation. But what if the patient not remove the dental plaque from the oral cavity? If we have enough time, the dental plaque can minorize, and we receive another deposit. But before, we can demonstrate it, the patient, the invisible plaque with a plaque painting. Okay, so it's a good thing because we can show the patient an oral situation, and we can use for patient motivation this thing. Yeah, this is the result after the plaque painting, and we can, if it's after the tooth brushing, we can inform the patient the oral hygiene. The oral hygiene level is not acceptable because we have so many plaques, as you see, okay, especially the front area, especially the approximal area. It's very important to clean the approximal region because the periodontal inflammation always starts this area. So this is good for the patient motivation as well, and it will be evident for patient where is the plaque. So, as I told you, if the plaque removal is ineffective, the plaque can minorize, and the minorized plaque we receive a different deposits called dental calculus. Okay, this is the dental calculus. It's quite large deposits, and the problem is why this wrong situation? So it's not a natural product in the oral cavity, because you should understand one important thing in the third year. So the dental calculus is necessary to remove from the oral cavity because the surface of the calculus is always a rough surface. If you compare the tooth surface is smooth, the calculus surface is rough. And the rough surface is very optimal. The colonization of the bacteria. It's much more easier than do the colonization than like a smooth surface. And these bacteria localize nearby to the gingival margin, and this bacteria can produce a huge inflammation, which is inflammation could be irreversible, and receive a patient spontaneous tooth loss. As you see, this is not a normal condition to see the patient tongue by the centric occlusion. Okay, so it's not normal. And unfortunately, this is the end of the inflammation of the periodontal tissues, the spontaneous tooth loss. And just another important information for you: mostly this process is painless. Okay. If theoretically it will be painful, of course the patient have to go to the dentist, but it's painless condition mostly, and it's quite irrelevant to most of the patient to cure this condition. During the practice, we will learn how we can remove, the dental calculus from the tooth surface, of course. We have different methods, and the phantom lab practice we will learn how can we remove it. We have two theoretical options you will see. One is the ultrasound, of course, and the hand instrumentation. So, yeah, not a good example for a typical Hungarian patient. Unfortunately, so this is a reality, guys. So you will see in the fourth here. So it's a painless condition for patients. Okay.
The white part is plug or pulse? Which
My opinion is a plaque. Okay. And you have to say, so we have a very corrective sign of inflammation. This inflammation is irreversible, of course. There's no question. It's not possible to cure with a proper brushing because it's too late. Okay, so we need a patient need a professional treatment. It will be your job to remove the deposit in oral cavity. Okay. One additional information: why we have to remove the calculus from the oral cavity. As I told you, so the surface is always rough and it's a plaque retention area, and we have to reduce the plaque retention area into our cavity. And so it's not irritation. So the calculus is not the primary cause of the periodontitis. This is the basic information. But the surface, which is covered with plaque, can produce gingivitis or severe situation periodontitis. So the localization of the calculus could be supra and subgingival, okay? And also you have to know, theoretically, this was a subgingival calculus because the subgingival calculus is always black, okay? The supragingival, it could be white, could be yellow, could be different colors. Okay, and also you have to measure, the gingival margin, the shape of the gingiva, and something like that.
Sure.
So it's quite terrible situation. Not a good example. Huge calculus deposits. You see, the color is it's a yellowish condition, but it's quite huge. Okay, and the gingival margin is also not optimal. So I think it's quite sadly situation.
How can you become like this?
Because it's painless. It's painless condition.
You don't see your teeth go?
They don't care.
It's irrelevant for a patient, the aesthetic things mostly. Okay.
How they
it's-
can chew?
Yeah, because I don't know. The patient can solve this problem. I don't know how, but
Yes,
they can do it. But the chewing is not effective because the calculus. Growing the large calculus, we need the food impaction of well, and the chewing is a little bit against the calculus formation, so it's not 100% true, I know. But here, I think it will be very ineffective chewing, so it's not optimal. Yeah. Subgingival calculus, the black. Okay, it's a little bit bluish, you see. So this if you see something like that by a patient, so this bluish blackish thing, so it's always the calculus. Yeah, it's not caries, because it could be mistaken with a caries. This is a caries, okay? This is brown thing, but this is not. This is a subgingival calculus, okay? And sometimes the patient is also mistaken with a caries, and the patient say, "I have a caries, the lower incisors." Of course, it's not. It's a calculus deposit, okay? And also maybe here is also visible the plaque formation as well. So it's quite that dangerous situation because it could be irreversible as well. Okay, so the last part of this lesson, so we have to discuss the classification of the gingivitis and the periodontitis and the periodontal problems. Let's see first the gingivitis. The situation is not so simple, but the third year is very important to understand the plaque-induced gingivitis and the plaque-induced periodontitis. In the fourth year, we will discuss more details as well. So, plaque-induced, it's mean if you remove the plaque, we can prevent and we can heal the gingivitis. The gingivitis is a reversible condition, okay? This is very, very important to know. I wrote something which is valuable, and also you can see we have so many alterations of the normal gingival color contour and something like that. And the most important thing, we receive this thing, bleeding upon provocation, bleeding upon probing. This is a dental probe, the periodontal probe, and it is not sharp instrument. You will see, in a practice, it's rounded because it's a ruler. We have to check. We have to determine the pocket depth. Of course, there's no pocket by the gingivitis, but we receive bleeding because we have in a microscopic examination we can see so many small ulcers into the gingival sulcus, and if we touch it, it can bleeding very easily. So that is the source of the bleeding. So it's not irritation. Not irritation with the probe, it's due to inflammation. So bleeding during probing, bleeding during tooth brushing, so this is the characteristic sign of the inflammation. Okay, please memorize these things. So this is a common clinical change for half-field gingival to gingivitis. So we're changing the color. So it's more reddish, more bluish condition as we see in the previous pictures. The size, the shape, the consistency, and the bleeding tendency, okay? So this is, I think this is also part of the minimum knowledge to memorize these things. And if, theoretically, the fourth year, the patient will ask, is any kind of medicine against the gingivitis and bleeding?
Toothbrush.
Of course it's toothpaste. Okay, there's no special drug for this, and just the proper oral hygiene, don't forget it, okay? No antiseptic solutions, nothing, no chemical agents, nothing, just the brushing.
Anti-inflammatories.
Anti-inflammatories,
Not steroidal.
yeah, theoretically, okay, we know this is a bacteria, okay, and we can prescribe antibiotics, of course, but it's just a long, short term. And prescribe antibiotic in a case of gingivitis is a mistake. Okay, so we have to achieve a local treatment. Local treatment is a proper oral hygiene. That's all. Okay.
Mouthwashes?
Uh,
No.
maybe the prevention. Okay, maybe the prevention. For example, we have a certain morphosis which is available in Hungary as well. It's essential oils, for example, it's Listerine or something like that. It's good against the prevention, but not for therapy. Okay. So it's much more easier to do the prevention. The therapy is not available. Okay.
This is
What
it.
about
Sorry.
what about the patient who needs root canal treatment and already have gingivitis? So do we prescribe antibiotics before we start the
It's not
treatment?
necessary because there is a different etiological factor for the gingivitis and the pulpal infections as well. Okay, so you should understand one thing. It's a local problem. It's a local problem. I mean, the gingivitis is also the local problem, and if we have the pulpal infection, it is also a local problem in the first stage, of course. And we have to solve this problem with a local therapy. Okay. And we should avoid to prescribe antibiotics. Okay, certain situation we need antibiotics, but not in the case of the gingivitis. Okay, not in the case, for example, pulpitis. Okay, of course not. We have more severe inflammation, for example, periostitis or something like that. It's a limited situation, and that situation we need antibiotics. Otherwise, it's not. Okay, just a local treatment. And as a dentist, you have to do, for example, professional cleaning to reduce the gingivitis level, or the root canal therapy in the case of pulpitis or pulpal infections. Okay, so not the antibiotic. Antibiotic is not a good solution. Okay, for local problems.
What if the patient doesn't have bleeding while brushing, but bleeding while flossing?
It's the same situation because it is also show us we have inflammation. Okay. Theoretically, improper using of the dental floss can produce also damage of the interdental area. But theoretically, if we have flossing and bleeding, it can show us inflammation as well. Guys, and you have to know one important thing. The periodontal inflammation always starts the proximal area, okay? That ratio is important to explain the patient why we need to use dental floss, okay? Because the question is always why. Because if we want to prevent and treat gingivitis or prevent the more serious complications, we have to use the dental floss. Okay, there's no alternative for this. It's not enough to use antiseptic solution. Flossing is essential, and you will see in Hungary it's a big mystery. Okay, so nobody want to use dental floss. Okay, that's it. Yeah,
If we use the proximal brushes,
unfortunately, the approximal brushes not for everybody, because if we have anatomical situation, no attachment loss, and we have a normal interdental gingiva, there's not enough space to use interdental brush. Okay, interdental brush is necessary, but not. Yeah. Okay, this is some of the picture about the gingivitis, guys. Let's see again. So this is the alveolar bone, this is the periodontal ligament, this is the gingiva and the seventh layer. So the inflammation is localized, just the soft tissue, okay, the gingiva, that's razor is reversible. Okay, this is a happy situation, this is the inflammation. And okay, this is a clinical picture, so this is completely reversible situation. This is good news for patients, so we can cure 100%. But if we don't know the border between gingivitis and periodontitis, but the periodontitis is irreversible condition, and it will be the next step. It's a not automatic process, so the gingivitis can persist for years. And after you see periodontitis, we don't know when, but if we have this thing, the periodontitis is irreversible. And we are talking about the chronic periodontitis. A chronic means it's also pain-less condition. There is no pain at all. So we have some symptoms. Of course, we have the gingival inflammation. There's a previous sign, and we have some additional thing which is necessary to know. The most important thing is a pocket formation. I already told you something about the gingival sulcus, which is a normal condition, and we know it's a very shallow space between the free gingival margin and the tooth surface. But in a case of inflammation, it's getting larger and deeper, which is quite impossible to reach with oral hygiene, cleaning. I mean the brushing and interdental cleaning. So the patient, if we have a periodontal pocket formation, the patient need professional treatment. That will be your job. Okay, to clean the root surface, because it's impossible for a patient. Of course, we have some other things we will discuss in the practice also. What does it mean? The loss of clinical attachment, loss of alveolar bone, and mobility. This is also alarming for a patient, because it's not optimal. Let's see the pocket formation. It's actually important to understand this situation. Theoretically, the gingival margin attaches strongly to the CEG, okay? And normally we have just a 3 millimeter deep gingival sulcus, which is normal condition. But in the case of the periodontitis, we have alveolar bone loss, we have attachment loss, and also we the gingival sulcus is getting deeper. It's called this area is called periodontal pocket. This is the perio probe. This is a millimeter measurement. So 3 millimeters normal. This is 1, 2, 3, 4, 5, 6 millimeter deep pocket, which is pathologic. Okay, and unfortunately, this is irreversible. Why is it irreversible? Because we have a bone loss. Okay, don't forget it. If there's no bone loss, it's a reversible condition. The inflammation is not localized to the soft tissue. It's reached the hard tissue as well.
So how do you treat it?
Yeah, that's
Surgical?
we will discuss in the practice. So briefly, we have to eliminate the bacteria, because we know this is there's a bacteria, these black things. We have to eliminate the bacteria from the root surface with a hand instrument and with the ultrasound as well. So this is the primary
scaling
goal.
is the first.
Sorry?
So scaling is the first.
Scaling is the first. Always the scaling is the first. Okay, this will be the final.
Treated surgically or like?
Yeah, the surgical treatment we will discuss in the 4th year. So, just one additional thing: the surgery. I mean, the periodontal surgery is not for everybody. Okay, it's just an option. if we have so many anatomic problems which is not reachable with our oral hygiene instruments, okay? So that's the situation, we have to do the surgery, but the surgery, the keyword is a cooperation. If there's no cooperation with the patient, so the patient not doing very well the oral hygiene, we can measure it, so we can measure the plastic, for example, is it not available for a patient. If the patient is a smoker patient, also not available for a surgery, okay? And of course we have so many general conditions, this is not available, the surgery. So the surgery could be the options, but not for everybody. But you know, the root surface cleaning and the scaling is for everybody, and that will be your job, or maybe the dental hygienist job. But if we have a deep pocket, you know, we have to do you know, the cleaning of this pocket with the hand instruments and the ultrasound, the combination of the ultrasound and hand instrumentation. X-ray is also important. You will learn it in the second semester. Guys, unfortunately, the X-ray is not a primary during the periodontal examination, so it's valuable. But as I told you, the gingiva is invisible in the X-ray. So as a periodontologist, we prefer the clinical examination, not the X-ray. X-ray is a supplementary. We can check the bone level, but we can't see the gingiva, and this is not optimal for us. Yeah, and this is the typical picture of the periodontitis. You see, it's a painless condition for a patient. Let's see, this is a healthy situation.
Pain just watching it.
Yeah.
And this is the periodontitis. The periodontitis, we have a deep pocket, we have inflammation of the gingiva, we have a bone loss, we have an attachment loss, we have a loss of our ligament, we have a huge calculus deposit, as you see.
Extraction?
It depends on the situation, but it's quite,
Not this sort of
guys, it's quite hopeless situation, because you can see there's a huge gap between the thing, and normally there wasn't gap, and if we have gap, it's very characteristic sign the attachment loss as well, and the oral hygiene is not optimal, so maybe we can try to improve the oral hygiene level, but if there's no motivation of the patient, so the only solution is the extraction. So unfortunately, this will be the reality. You will see in the fourth year, so you will receive so many extractions because we have, you know, a patient something like that. And you will see this thing. And of course, the patient needs a prostate treatment after this, so it's quite an optimal situation. And this is my last slide, okay? So this is also reality. You will see patients something like that. Of course, it's not for the periodontal treatment. It's too late. It's too late to solve this problem. Okay, the only solution for patients is the extraction. Just note this hose. It's a spontaneous. It was a spontaneous tooth loss. Okay. So unfortunately, the patient.
Filling.
The grayish thingy.
No. It's a crown. It's a crown. But you know, the covering of the crown is partially missing.
Metal framework.
And the pontic is missing. Maybe.
The pontic is missing. Yes.